Nurses, patient advocates, humans of the earth, let's have a chat. Can we talk about something here? So, as some of you may know, I am a private patient advocate. I have my own company that I have been slowing down over the years, and I really only take pro bono clients for the most part, unless you've got, just a huge need and something that I can really do within the constraints of my current time situation. That said, I have been taking pro bono clients because several people I know have been hospitalized, needing health care, really needing some guidance, and reached out to me, and I'm more than happy to do that if I have time. So I'll leave that there. I have a new client. It's a friend of mine. I said I would help her. I didn't realize she was hospitalized, and I was really shocked at what she told me. I don't know why I was shocked at what she told me or what she shared. However, I did speak with the chief nursing officer today, who's now addressing some of those concerns, and will be getting back to us. But it's really important when you're in the hospital or when you're helping somebody in the hospital, your family member, they don't want to be in that bed, right? And as a nurse, new nurses, please listen to this. The patient does not want to be there 99% of the time. We may think people come in for free sandwiches, drugs, whatever it may be, but honestly, they would rather be somewhere else. Nobody wants to be in that bed. It is part of our job, if we're a bedside nurse, if we are working in a hospital, if we're working in home care, any situation dealing with patients, any kind of setting, that we deploy therapeutic communication, that we act as advocates for our patients, and that we are kind and compassionate, if nothing else, and that we communicate what we are doing. What is the plan? In a hospital setting, we already know the drill. We know there's the whiteboards. Have you explained the plan to the patient? Does the patient know who their doctor is? Do they know the plan of the day? Are any precautions or risks, identified? Is their, whiteboard complete? Do they know what room they're in? Do they know where they are? Do they know their nurse's name? Have you introduced yourself, and do you introduce yourself frequently throughout the day? Because guess what? If we're giving a lot of narcotics to patients, they may not remember. They may not be recalling the whole conversation with the provider. If you're the family member, the friend, the partner, the wife, spouse, child, daughter, parent of said patient, it's really important that you maintain a level head about you, and that you're dealing and addressing things in a concrete way, not from your emotions. I'm going to say this again. I know it's difficult because I've been there. We've all been there. We've all been there and been escalated and tagged and annoyed and irritated and beside ourselves caring for somebody who we love or for ourselves. It's really important that you just stay factual and really know who your audience is. You're not going to talk about the food to the doctor. You're not going to talk about the medication to the person from lab. You're not going to talk about the lab draw and how that went with the person from housekeeping. They're not the right person, right? So make sure that whoever you're speaking with to address your concern, are you speaking to the right person? I knew what was going to happen when I left a message is that somebody from patient relations was going to call me back. Sometimes these are called the patient navigators. I don't know why hospitals use this term. I think it's ridiculous because they're not navigating anything. They're trying to navigate and manipulate perception, but they're actually not in any position, nor are they clinical. I've never met a single person in patient relations who is clinical, who can actually take a look at the chart and address a specific concern. They are there to do patient relations, which is an arm of public relations. They're not there on the clinical side. So it's a little disingenuous for hospitals to say, here's a patient advocate, because that implies they're advocating for the patient. No, they are not. They are advocating for the hospital to ensure that you don't complain or give them a bad review and then make you think something's happened. But here's the problem, hospitals, is it backfires. It has patients believe somebody's advocating and something is going to be addressed. And when that doesn't get addressed and that patient advocate isn't reachable or doesn't follow back around because they work Monday through Friday, 9 to 5, what do you think that does? What do you think that does? That does not help anything. I got that call back from the patient advocate, and I said, I understand you're the patient advocate. Respectfully, I know you work for patient relations. I understand patient relations very well. You're not the person who can solve the problem. I need to speak with the person who can solve the problem, who is the director of the unit. It's going to be the chief officer, chief nursing officer, VP of nursing, whatever they're called, depending on how they name them in the hospital. Not somebody from patient relations. Now, I may need to speak to somebody in risk management if the issues don't get resolved by a clinical person, but I don't need to speak to patient relations. That's a different scenario, and honestly, patient relations should be intervening at the front end and ensuring and preventing some of the issues from happening. But if you say you're going to solve a problem and then you don't solve that problem, the problem continues or gets worse or additional problems arise, now you've really created a bad situation. And depending on the state you're in, the Nurse Practice Act, the licensing for hospitals, and I'm very familiar with the state that I'm dealing with this person, there's a lot of repercussions to what is being alleged and what is been witnessed, and then the chart doesn't lie. So when I tell nurses, so nurses, listen up on the nursing end, when I say to you, if you did not chart it, it didn't happen. Because on my client, we're going to do a chart review, and we're going to see the timing of medications, assessments, reassessments, and we're also going to check the timing of when consents were signed, whether or not analgesic narcotics were given just prior to this individual signing consent for a procedure. These are things that we have to be mindful of. You may think I'm checking the chart, I'm doing X, Y, and Z, but if you're not documenting it and it's not recordable and it cannot be validated, you did not do it. And if the drugs you're giving, the medications you're giving for pain management don't match up to the patient's pain level, or the pain level you've charted doesn't match up to what the patient is saying their pain level is, and doesn't corroborate with what the doctor or provider's note says, there's going to be issues. There's going to be issues. So let's just take care of our patients, okay? And then we won't have to deal with any of these issues. And if you're trying to resolve an issue as a family member, as a patient, do your best to figure out and identify who is the person that you need to speak with who can solve your issue. Because otherwise you're just wasting your time. All right, that's my TED Talk. We're going to talk about this a little bit more because nurses, we need to do better. Repeatedly failing a patient is not acceptable. Again, it's our job, our duty, our ethical duty to be advocates for patients and to provide care and to manage the care of the patients, right? And to execute those orders. So we can do better. Let's do a better job.